Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to both understand and perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics that we all have to engage with in daily practice. Valvulopathies, cardiomyopathies, systolic and diastolic function and dysfunction, and also the new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in imaging and echocardiography, and I will guide you through clinical cases and talks from my clinical experience addressing a wide range of echocardiography topics. My imaging, the images that you will see in my talks, are all based from my experience in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is not only a YouTube channel, it is also a website, echobyweb.com, where you will find much of the materials I will present you in this channel. So let's have a look. This is the homepage of the website, echobyweb.com. Up here in about, you will find my credentials. Under Atlas, you will find 2 atlases of imaging, transthoracic and transesophageal. It's work in progress. Under Ecolab, you will find normal values for echocardiography, scores like the Wilkins scores, the Montgomery plaque classification, and analysis and quantification of the left ventricle, the mitral valve. And then you will also find formulas and calculations, guidelines, references, an example of a complete echocardiographic examination. You will also find here online calculators, which are Excel spreadsheets on the website with which you can interact, and you can make a lot of calculations, stroke volume through the valves, and you can find the indications for valve surgery based on the latest guidelines, European guidelines, and you can find also flowchart for the calculation of diastolic function from the latest recommendations. And this is the QR code with which you can access, for example, if you have a cell phone. The topic of this talk, which spans over 5 videos, and this is the 3rd video, is the echocardiographic analysis of the left ventricular systolic function and dysfunction as seen in the real world. This is, of course, a basic approach to the topic, which is quite large. Now, these talks assume that you have a basic understanding of how to perform pulse Doppler and continuous Doppler and of interrogation of intracardiac flow, how to perform tissue Doppler, and how to perform M-mode 2D measurements. However, you will find on the associated website echobyweb.com that I mentioned before a large quantity of educational materials that address these topics. And this is the outline of this talk on left ventricular systolic function. We begin with an introduction and definitions. Then we move on to physiopathologies and define the determinants of systolic function. We analyze the pressure volume loop as constructed invasively, and we see how invasively we define left ventricular contractility. When we move on to the aims and the qualitative evaluation of left ventricular systolic function, and then the mechanical function of the left ventricle through ejection fraction, and how to perform stroke volume assessment and cardiac output. And then we have the echocardiographic estimation of left ventricular contractility using isovolumic phase indices like the noninvasive dP/dt from mitral regurgitation and the Myocardial Performance Index or TAE index. And we end with the analysis of left ventricular longitudinal function using tissue Doppler, because strain analysis will be the topic of a whole new another video. And these are how they are grouped in the 5 videos. And this is video number 3, left ventricular mechanical function and the analysis of how to perform ejection fraction. left ventricular mechanical function, and ejection fraction. So we have stated in the previous slide that ejection fraction is stroke volume, which is end diastolic volume minus end systolic volume, normalized by preload, so end diastolic volume of the left ventricle. So ejection fraction is dependent on preload. But the ejection fraction is also very sensitive to changes in afterload. We have seen this when we have discussed the systolic function afterload relation. And it is moderately sensitive to changes in preload, and we have seen this from the Frank-Starling law. Ejection fraction is also inversely related to heart rate. These on the lower right panel are the 5-95% confidence intervals divided by sex. In males, the ejection fraction will go from 52 to 72, in female from 74 to 74%. But every echocardiography lab should have its own normal values. And thus, these are the normal values for left ventricular volumes and ejection fraction, which were seen in the Italian lab where I worked on a population of 167 normal subjects which were screened. Mean age was 47, between 18 and 87. This is the body surface area, and this is the mean arterial pressure. And so ejection fraction here, the mean was 63 plus or minus 5, and the confidence interval were 56 to 73, a little bit different between those normal values published in the literature. I really think that every lab should have, for every value of echocardiography, its own normal values. The methodology to obtain good planimetry of left ventricular volumes with the aim to calculate the ejection fraction on your machine is addressed in the talk dedicated to the evaluation of volumes and mass that you can find on this Echo by Web YouTube channel. It's another talk. Once you have performed the planimetries that you see here of the end diastolic and end systolic volumes in both the 4-chamber and the 2-chamber views, so to calculate the biplane ejection fraction, it is important to consider all the information that is provided by your ultrasound equipment. In the results panel on your machine, you will find the volumes, you will find the 2D stroke volumes, the biplane volumes obtained, and the stroke volume obtained from the volumes. And I usually discard the 2D stroke volumes on a machine because I think that pulse Doppler stroke volume it's much superior, more reliable. But the very important measure here is the left ventricular long axis, the end diastolic long axis. You should always compare the end diastolic long axis obtained in a 4-chamber view from that obtained in a 2-chamber view, because there is always the possible pitfall of foreshortening the 4-chamber long axis end diastolic, and which would impair your ejection fraction. The values should be within 5 millimeters, like here in this example. So be careful not to obtain a shorter long axis in the 4-chamber compared to the 2-chamber view. If if there is a difference of more than 5 millimeters, you should obtain another planimetry. You will find a detailed discussion of the problem of the geometry of the ventricle and the foreshortening in the 4-chamber view in the talk on this channel dedicated to volumes and mass that I just talked about. Additional information can be obtained on your machine on some echocardiography machines if the end diastolic and the end systolic planimetries are shown superimposed, as in this case. In this case, if you have the end diastolic and end systolic long axis, the apex point of them superimposed, you can have a little bit more information, because you can have, for example, the extent to which the base of the heart, the mitral annulus, moves towards the apex in systole. This is known as the systolic descent of the cardiac base, which is a measure of the longitudinal function of the ventricle. We will talk about this later. A common method used especially in the States, I think, United States, to estimate ejection fraction is known as eyeballing, which means exactly that. You estimate just by looking at the change of the area in the 4 and 2 chamber and the 3 chamber view of the left ventricle. So the operator observes in multiple views, also in the short axis, the motion of the walls of the left ventricle, and then estimates an interval of ejection fraction, for example, between 20 and 30 or between 55 and 17%. This very subjective estimate of ejection fraction is historically the most widely parameter of left ventricular systolic function used. It has also been published. It is practical, has been demonstrated in the literature to be accurate and reliable, but necessitates, of course, I think, of a lot of experience. It is essential to have good quality 2D imaging where you can see very well the endocardium and be able to evaluate, as I said, the multiple orthogonal views. So I think not only apical but also the short axis. I personally don't use this method. I prefer to have a specific number and measure the planimetries. I think it is more accurate, but this is just my opinion. And then if you have the technology available in your lab, there is a 3D technology, which today is fast and accurate, much better than when it was introduced years ago, although you still need a baseline high-quality 2D imaging as a prerequisite. There are different softwares available. This is one example. They are semi or fully automatic, but of course you still need to carefully check the correct endocardial recognition by the software before using the numbers. Here you see with this software, but with all the softwares, you also have a very nice volume curve of your ventricle. But what I think is one of the most interesting things, advantages of this technique, is this multiple short axis, this short axis multi-slice option, which allows you to perform a detailed analysis of myocardial structure, cavity geometry, endocardium, thickening, of global but also segmental function of all the left ventricle from the base, the mitral level, to the apex. I think this is very interesting and very, very useful. And how reproducible is our biplane ejection fraction? Reproducibility is quite good, as shown here. There are some critical voices in the literature, but I think that the problem is that at times operators who have not fully undergone a complete learning curve are included in some series explaining the not very good reproducibilities published in some papers. This is the analysis of reproducibility of volume and diastolic and systolic and ejection fraction performed from this paper, which looked at comparing reproducibility of 2D volumes ejection fraction against longitudinal wall deformation. This is a 2015 paper. This table shows the values for the 2D variables, the diastolic and systolic volume and ejection fraction. And from left to right, you have the statistics, you have the bias, the repeatability coefficient, CR, the mean percent error, MPE, and a coefficient of variation values. And from top to bottom, you have the analysis for intraoperator, interoperator, intercycle between different cycles, for example, the first and the third cycle, the first or the fourth, and test, retest, so the examination performed baseline and after a week. As you can see, reproducibility is best for end diastolic volume, then comes ejection fraction, and last end systolic volume. This is intraoperator, but the same is for interoperator. See, best for end diastolic volume, then ejection fraction, then end systolic volume. I'm looking at coefficient of variation, but the other statistics are similar. This represents excellent reproducibility, superior to most previously published series. And this can be due to different factors. Also because previous series were quite old, so 2D imaging in this series is much better. The resolution of the machine was much better than previous series. And for your information, let's see some definitions for the statistical tests that were used for this analysis. So bias here is the mean of the differences between two sets of measurements. The CR, the repeatability coefficient, is the standard deviation of the bias multiplied by 1.96. The mean percent error is the mean absolute difference between measurements divided by the mean of the measurements and then multiplied by 100. And the coefficient of variation is the standard deviation of the mean variances divided by the mean of the two sets of measurements. Now let's look at the limits of the measurement of ejection fraction. The most widely used number in cardiology is undoubtedly left ventricular ejection fraction. But every parameter we use, in this case a global function parameter that approximates what we actually want to measure, which is contractility, every parameter has limitations, regardless of the imaging method used, ultrasound or MRI. In the case of ejection fraction, remember that it is influenced by preload and therefore, for example, by mitral regurgitation, which increases preload. And it is influenced a lot by afterload and therefore, for example, the blood pressure which is present at the moment that you do your examination, and for example by aortic stenosis. In this regard, remember the very close inverse relationship between afterload and ejection fraction, always. The ejection fraction should always be calculated using the biplane method. This method is the closest to the calculation performed by 3D technology. Also remember that while 3D includes all myocardial segments in the 4, the 2 and the 3 chamber in the calculation, the biplane method excludes the apical three chamber view. So it excludes the anterior septum and the posterior wall from the calculation. So function may be overestimated, for example, if one of these two walls is akinetic, or underestimated if there is, for example, an aneurysm of the inferior wall. But why, you may ask, I should calculate biplane ejection fraction, for example, in a patient with a hypertensive heart disease and a symmetrical left ventricular hypertrophy? Isn't a unidimensional value the same, for example, an M mode value, or a simple radial shortening fraction that you have with M mode? Aren't those sufficient? The answer is no, it is not sufficient for a purely methodological reason, or rather for a reason of quality of work. If you limit yourself to measuring ejection fraction, biplane ejection fraction, only in a few of your patients that really need it, with a severe reduction in a cardiomyopathy, for example, you will never achieve an optimal accuracy and reproducibility, which requires long-standing experience and mostly constant commitment, like an airplane pilot, which bases his experience on hours of flying. A constant commitment to the task of measuring the planimetries and ejection fraction will deliver accurate and also fast measurements of ejection fraction. Remember that it's also interesting and important to measure also stroke volume, which reflects better the hemodynamic status and patient's symptoms. And as a matter of fact, a reduced ejection fraction does not necessarily imply reduced stroke volume or cardiac output. You can have a very dilated ventricle of 250 milliliters of preload and diastolic volume, a severe reduction of ejection fraction, like 35%, and your patient may just not complain of any dyspnea or mild exertion, as even a small amount of radial function is enough for that very dilated ventricle to produce a sufficient stroke volume for rest life or just mild exertion. And now a quick look at the influence of heart rate on ejection fraction. In the upper panels, 4-chamber and 2-chamber, the patient has a normal heart rate of 75 beats per minute and a severe reduction of ejection fraction. It is 29%. In the lower panels, the 4-chamber view and the 2-chamber view, here we have the same patients with sinus bradycardia at 35 beats per minute, and the ejection fraction has climbed up to 45% due to the recruitment of preload through the Frank-Starling mechanism. Secondary to the longer filling period, the ventricular filling increases and a higher preload is attained, which increases systolic function and stroke volume. And now let's look at the influence of afterload and contractility on left ventricular mechanical function, ejection fraction. In this slide, we see different patients with different degrees from B to D of systolic dysfunction compared to a normal patient in panel A. 4-chamber view on top, 2-chamber view below. In B, the reduced ejection fraction is secondary to an increased left ventricular afterload because the patient has a moderate aortic stenosis, calcific. This creates impedance to outflow. As we have seen in the previous slides on physiopathology, afterload is the main determinant of systolic function, and there is an inverse relationship between afterload, which when increases, decreases ejection fraction. In C, the mild reduction in ejection fraction is secondary to reduced myocardial contractility in this patient with a mild dilated cardiomyopathy, whereas in D, there we observe a severe reduction of ejection fraction secondary to a severe reduction or reduce of myocardial contractility. So here, and myocardial contractility is the main determinant of ventricular systolic function. So normal ejection fraction, reduced ejection fraction due to a reduction in afterload, and ejection fraction reduction due to a reduced left ventricular contractility. As a matter of fact, when we measure ejection fraction in our routine practice, our double goal is that to measure systolic function, but also and primarily to estimate contractility of the left ventricle. So it is very important in our diagnostic workflow to be able to discriminate between a reduction in ejection fraction secondary to a reduction in contractility like in C and D, and to distinguish it from a reduction in afterload with unchanged contractility as in the patient in B. Now let's look at the usefulness of the determination of ejection fraction. Now, to be able to accurately and reproducibly determine ejection fraction is central in our work as cardiologists and echocardiographers. These are the new definitions of heart failure phenotypes: heart failure with reduced ejection fraction, mildly reduced and preserved. And you see here that it is crucial to differentiate ejection fraction with these cutoffs. So with reduced ejection fraction means that ejection fraction is 40 or less than 40%. The phenotype with mildly reduced ejection fraction you measure between 41 and 49, and with preserved ejection fraction, the phenotypes, the ejection fraction must be 50 or more than 50. So for example, 37 ejection fraction will be different from 42, even if there is only 5% difference, and 45 will be very different from between 51. So we must attain the accuracy such that we are able to differentiate between these different phenotypes in our patients. Likewise, it is crucial for us to differentiate ejection fraction of 33 from 38. In one case, the patient will have CRT, in the other one, he will have not. So, very important to be precise with ejection fraction. And ejection fraction has been an important determinant of patient prognosis on top of the clinical evaluation that meets New York Heart Association here. There is a large consensus in the literature and it is widely used for this. On top of ejection fraction, we see the value of diastolic function and filling pressures here. And lastly, also the changes in ejection fraction, for example, during patient follow-up, have been shown to have a prognostic value, as you can see here on the graph. This is the follow-up, and you see that the change in ejection fraction have an important prognostic value. A decrease in more than 10% here is much worse than a decrease in 5%. And finally, ejection fraction is the cornerstone of cardiological epidemiology. You can see in all these studies the use of ejection fraction and looking at the prevalence of left ventricular systolic dysfunction, and these are the different cutoffs that have been used to define left ventricular dysfunction as mild, moderate, or severe. And this is the end of video number 3 of the echocardiographic analysis of ventricular systolic function. Please proceed now to video number 4, which deals about left ventricular mechanical function, and specifically stroke volume and cardiac output. And you are on the Echocardiography channel, a channel for cardiologists, sonographers, but not only, a channel dedicated to echocardiography in real-world analysis. And see you in the next video.